Much of my talk really interdigitates well with Mimi's. She had a quote from William Osler, and I'll show you that this quote from William Osler, which I use to sort of define what it is we're talking about in integrative oncology, was actually a paraphrase from Maimonides, who said it hundreds of years earlier. It is more important to know what sort of person has a disease than what disease a patient has. So as mentioned, I'm chief of hematology oncology at San Francisco General Hospital, which is our safety net hospital where I see patients who are medically indigent, usually through an interpreter. And I also practice integrative oncology consultation at the UCSF Osher Center for Integrative Medicine. And what I say is that at San Francisco General Hospital, I treat cancer, and at the Osher Center, I treat people living with cancer. And so that's a bit of a difference. So what is integrative oncology? Because of the requirement that we not use copyrighted photos, all of my slides have now been retouched by me going through my solar eclipse travel pictures. There was just an eclipse 2 days ago. I don't know if people are aware. It's the first eclipse that I've missed in 19 years. I've seen every total solar eclipse over the past 18 years. So this brings me back to my solar eclipse travels. So you'll see a lot of, anyway. So integrative oncology, I would say, is the rational, evidence-informed combination of conventional therapy with complementary interventions into an individualized therapeutic regimen addressing the whole person, body, mind, and spirit, living with cancer. And it's important to note the one word, or that you'll say, what does he mean, is we practice evidence-based medicine. What is evidence-informed medicine? And I think it's, the degree of evidence that we have for many of the recommendations that we make is more informed by the evidence rather than based in. And Andrew Weil, who's one of my mentors, often says that the degree of evidence should be directly proportional to the potential for the intervention to do harm. So if I'm going to say I'm going to give you new chemotherapy regimen, your hair is going to fall out, you're going to vomit for 4 days, and your bone marrow is going to be suppressed, you're going to say, where's the evidence that it works? If I'm going to say eat more blueberries and get a massage twice a month, how much evidence do we really need to have? So integrative oncology provides relationship-centered care. And this is, I think, really critical because oftentimes I'm barraged by emails or telephone calls asking me questions. Can you tell me what to do for my sister? It's very important that I interact with the patient because it is, as this says, research suggests that our presence as medical or mental health clinicians, the way we bring ourselves fully into connection with those for whom we care, is one of the most crucial factors supporting how people heal, how they respond to our therapeutic efforts. So the first thing I say to my patients at the Osher Center is, tell me the story. And I learn a lot from that initial response. What story? Or they hand me a sheath of lab tests, scans, and pathology reports. I say, no, that's not your story. Or their spouse starts answering the question. So you do learn a lot. And how long does the average physician wait before interrupting a patient on the first question? 18 seconds. So I listen to people's story, and I could go on. Sometimes I say, well, you do want to hear from me during this hour or two, don't you? But so it's not just about a complementary therapy, but what we do is try to integrate conventional and complementary methods of treatment and prevention, aiming to activate the body's innate healing response and using natural, less invasive interventions whenever possible. Again, as mentioned, engaging mind, body, spirit, and community, and encouraging providers to model healthy lifestyles for their patients. I do, even though it's against California OSHA regulations, all my clinics are in the morning, and I drink 5 cups of green tea every morning. So I do model a healthy behavior, although, as I say, we're not supposed to have food in patient areas. So I may be breaking rules, but in any event, I think it's a good rule to break. Focusing attention on lifestyle choices and maintaining that healing is always possible, even when curing is not. So what about oncologists and their attitudes or knowledge about complementary and alternative medicine? Let me just say that CAM is something I think we really need to do away with altogether because it's internally contradictory. Something cannot be complementary and alternative really at the same time, because a complementary therapy is used in conjunction with and an alternative therapy is used instead of. Unfortunately, we now have the National Center for Complementary and Alternative Medicine at the NIH, which will keep CAM in our minds as an acronym for quite a while until hopefully someday they may become the National Institute for Integrative Medicine. So in general, patients we know are not enthusiastic about sharing their use of complementary cancer therapies with their oncologists because oncologists of all medical subspecialists may be the most reductionist. Again, because of the toxicity of the treatments we use and because that's actually our goal in treatment, is to reduce that tumor to absent. So patients fear that because their oncologists are so evidence-based that they will not necessarily look favorably upon their use of complementary interventions. And then the oncologists who are quite busy keeping up with the advances in the field for their particular organ, for example, cannot be expected to know everything that we're amassing in the knowledge base of integrative oncology. On the other hand, patients seem to use a bit of a different hierarchy for deciding what intervention they're going to use. This is a small survey of 34 men with prostate cancer in the United Kingdom, and they were asked on what evidence they based their use of particular forms of complementary therapies. And the number one source of evidence was personal stories of people that were helped by that intervention. Notice number 5 was scientific evidence. So I think it's important for us as providers to appreciate that oftentimes patients coming to see us are using a whole different standard of evidence than what we are used to in our practice. So what are the uses of integrative medicine in oncology? I think for reducing the risk of cancer is important, and I'm pretty big on thinking that another thing we need to do away with is cancer prevention. Robert Bazell from NBC News, the science correspondent, recently retired, is one of my dear friends. He said, Donald, if you can do anything in integrative oncology, please get people away from the idea of cancer prevention. Because I always see patients who come and say, I did everything right, why did I get cancer? And this makes people feel very guilty and ashamed. And you cannot really prevent some you can, but some you can't. So I'm on the National Cancer Institute Physician Data Query Complementary and Alternative Medicine, NCI PDQ CAM, editorial board. And in our postings, we often say cancer prevention. And I asked the editor if we could please think about changing that to reducing the risk. And he went to the Office of Cancer Prevention at the National Cancer Institute and lobbied them on my behalf. And their response was, gee, Americans appreciate cavity prevention, that toothpaste prevents cavities, and reducing the risk would be a concept that people probably couldn't get their heads around. Unfortunate. So you'll hear me try to say cancer risk reduction as opposed to prevention, and I think it sits better with the patients I see who have developed cancer and thought they were doing everything in their realm of possibility to prevent it. Then there's also people that believe that integrative oncology is useful in the treatment of cancer, and certainly, as we'll talk about, for symptom management and palliation of cancer. So with regards to cancer risk reduction, again, as Mimi was saying, it's very similar to cardiovascular risk reduction. We have pretty much the same guidelines, maintenance of healthy body mass index, regular aerobic and resistance exercise, and then dietary guidelines. And I took out the slide because I didn't have the copyright from the recent JAMA article on the state of U.S. health, 1990 to 2010, where they list in Table 3 the major causes of mortality and morbidity in the United States over that 20-year period. Surpassing tobacco, number one was dietary issues. Whatever that means, it's a bit vague, but it does not include excess BMI or physical inactivity, because they're number 4 and 5. So very important that these lifestyle issues are major causes of both cardiovascular and, to some extent, cancer morbidity and mortality. Useful interventions in smoking cessation, hypnosis and guided imagery, and acupuncture. And then we'll talk more about, certainly this morning and also this afternoon in my session, about whether supplements actually have any benefit in reducing the risk of cancer or slowing disease progression. With regards to the use of, let's say, alternative therapies for treatment of cancer, the evidence is far from compelling. And, you know, very, very frequently, I see patients who are coming to me seeking alternatives to standard interventions for their cancer care, and I explain, I've been an oncologist now for 30 years, and I'm very impressed with the advances we've made in the field, and I think it's better for you to be treated with conventional therapy. I'm also known as an investigator in medicinal cannabis. And right now, where I live and in certain parts of the country where cannabis is available, people are thinking that cannabis oil, which is a heavy concentrated extract of cannabis, actually cures cancer. And unfortunately, I'm seeing people in my clinic at the Osher Center who are deferring treatment of potentially curable malignancies to try cannabis oil as the treatment for their cancer. Again, I think there's no evidence that this intervention works, and it saddens me to have to explain that to people who, you know, may have actually lost their opportunity to successfully treat their cancer. I do believe that a very big role for integrative medicine is in symptom management and palliative care to relieve or prevent treatment side effects, improve immune function, and perhaps even alter disease progression. Do we have evidence that integrative modalities are prolonging survival? The answer to that question, I would say, is no, partly because it's very difficult to study. If I went to the NIH and say, I want to study integrative oncology in the treatment of cancer, they say, well, wait, what does that mean, integrative oncology? Narrow it down. Well, how about nutrition? No, what do you mean nutrition? Narrow it down. How about fruits and vegetables? No, narrow it. How about cruciferous vegetables? No, narrow it down. How about indole-3 carbonyl? Yes, you can have a grant. So, you know, that's reductionism at our National Institutes of Health. So when I see a patient at the Osher Center, I have a number of goals of this interaction. And number one is really to increase my patient's sense of control. Many people diagnosed with cancer are highly functioning individuals whose life has been their life until they heard you have cancer. And suddenly their locus of control has been removed. They're now at the mercy of the surgeon, the radiation oncologist, the medical oncologist, the chemotherapy nurse. And what we talk about during our initial hour provides the patient or returns to the patient some sense of their control. Mimi talked about inflammation. Inflammation, we now believe, is the main cause of many of the degenerative diseases of aging, dementia, heart disease, and cancer. And there's much that we can do to decrease ongoing inflammation in the body. And obviously, if we decrease inflammation, then we increase the body's innate immunity in the fight against cancer. When I ask patients, tell me your story, many people weave a story that suggests that stress caused their cancer. Stress, I don't think, is enough to cause cancer, but stress is adrenaline or epinephrine, which is lymphocytotoxic, and stress is cortisol, which is a steroid hormone, which is an immune suppressant. And studies have been done in animals that stress increases size and number of metastatic lesions. So stress is not something that's good for people living with and beyond cancer. And then all of these together serve to increase the patient's sense of hope. Many a patient leaves my consultation and says, Dr. Abrams, you're the first person that's given me any hope. And I don't tell them you don't have cancer or we're going to cure this or you're not going to die. but I've just given them an opportunity to increase their sense of control, and with that comes a sense of hope. So how do we increase the sense of control? Again, weight, as Mimi was mentioning, is not only a problem for people with cardiovascular disease, but as a potential cause and a negative prognostic factor for people living with and beyond cancer. So we can control weight by altering diet, and again, as Mimi said, increasing physical activity, use of appropriate supplements to help the patient get into the mind-body connection, just having them become aware of the breath, because as we all know, breathing is something we do autonomically, but then we also can control it by controlling and thinking about the depth and rate of our inspiration and expiration, and that is the sort of entry point into meditation, hypnosis, yoga to an extent. Connecting with family and friends. Very rarely does a patient come to see me in either of my practices by themselves, because cancer certainly affects more than just the individual. So I remind the patient that you have this community. I ask my patients right before I examine them whether they were raised with any religious beliefs, and if so, do they still practice them? If not, do they consider themselves spiritual? And then I ask them 3 questions. What brings you joy? What are your hopes? And where does your strength come from? And at the end of my consultation, then I can return to the patient that they still have, even though they're a person living with or beyond cancer, joy, hope, and strength. And for me, that's a little bit of the spirituality part that Mimi was just mentioning. So not to be too repetitious, I also love Hippocrates' phrase, let food be your medicine and medicine be your food. Myself, I've lived with a macrobiotic chef for 19 years, so this has become a bit of a tenet of mine. When I was in my fellowship at the University of Arizona for 2 years, the online distance learning fellowship in integrative medicine, that was the first place that I was exposed in my medical education to nutrition. And I kept coming home and saying, oh my God, you were right, because so 95% of Americans recognize tobacco as a cause of preventable malignancies. 92% recognize ultraviolet light because of the very strong lobby of dermatologists who have made us all heliophobic. Only 50% recognize that diet is a cause of avoidable malignancy, despite the fact that it accounts for probably as many avoidable malignancies as tobacco. However, it's much less clear the etiology or the link between diet and malignancy as tobacco, which is much more easy to quantitate, for example, in pack years. And when we talk about diet, is it what we ate yesterday for lunch, or is it what we ate during adolescence when we were developing, or in fact, more frightening, is it what our mothers ate when we were in utero? Because there is evidence from mouse studies, particularly the Ajudi mouse, that what's fed to the mother, both as food and supplements, can alter the epigenetics of the offspring, so that you can totally change the phenotype. So for my dietary recommendations, we have 2 good sources in the literature. Number one, every 5 years, the American Cancer Society comes up with expanded guidelines for nutrition, physical activity, and reducing the risk of cancer. And the World Cancer Research Fund, American Institute for Cancer Research, every 10 years puts out a 700-page compendium of data that's a global consensus of experts. And their 2007 recommendations, number 1 was to be as lean as possible without becoming underweight. And number 2 was to be physically active for at least 30 minutes each day. So again, very consistent with what Mimi was telling us for cardiovascular disease. And the American Institute of Cancer Research estimates that obesity-related excesses of these 7 cancers account for approximately 105,000 preventable deaths in the United States each year. Breast cancer, those 33,000 preventable deaths, are mainly postmenopausal estrogen receptor positive women. because there are so many women with breast cancer, even though this is about 20% of all breast cancer cases, it's a large number. Endometrium, for example, 50% of uterine cancer is felt to be related to obesity. But because the number is smaller overall, it's still less than the cases of breast cancer. And then you can see there's a number of GI malignancies and renal cell carcinoma, which are related to obesity. So how does fat increase the risk of cancer? Well, body fat secretes cytokines that promote inflammation, and as we mentioned, we're trying to decrease inflammation. Fat also produces estrogen, and that's why those malignancies, postmenopausal ER-positive breast and endometrial, which are driven by estrogen, are so heavily impacted by body mass index. Increase in body fat may also impair immunity. And for me, I think the most interesting, the most important link is probably with regards to too much body fat triggering insulin resistance, which raises the level of insulin and insulin-like growth factor, both of which promote inflammation and cause cancer cells to divide. In fact, that link is becoming so clear that they are looking now at blockade of insulin-like growth factor receptor 1 as a treatment, particularly in women with estrogen receptor-positive breast cancer. So the next guideline then is the first that actually says anything about food, and it says avoid sugary drinks. Up until 2007, the guideline said limit consumption of energy-dense foods, but in 2007, they switched it and put avoid sugary drinks as the one-liner. And I was at that conference in 2007. I went to the microphone and I said, there are sugary drinks and there are sugary drinks. You can drink a cola beverage, God forbid, or a fruit punch, which is probably glucose and high fructose corn syrup, or you can squeeze 3 oranges in the morning. And the response from the podium was, energetically, they're all the same. So Robert Lustig, who's our anti-sugar pediatric endocrinologist at UCSF, we had lunch together, and he explained to me that if you eat an orange, the fiber slows down the absorption of the sugar into the bloodstream. When you squeeze the sugar away from the fiber, it's like drinking a Coca-Cola. So why is that bad? You get that squirt of insulin and insulin-like growth factor, which promotes inflammation and causes cancer cells to divide. So does it mean I don't squeeze 3 oranges in the morning? I used to do it every day. Now I do it maybe twice a week. But I do get concerned about my patients who say, oh, I have cancer, so I'm going to juice everything. Especially juicing fruit, I don't think is a great idea to do every day. They all tell me they have this special machine that keeps the fiber in the beverage. Nobody's ever brought me a sample of that, even though I've asked many times. And this is just a picture from the health food market that I go to, where all of these fruit beverages are really hyped to be anti-cancer cures. Even pomegranate juice. There was a study that showed that 8 ounces of pomegranate juice decreased PSA rises in men with prostate cancer. I just don't think it's good to have that much of a glucose load on a daily basis. We know that there are a number of malignancies that are increased in diabetics, and they're very similar to the ones that are increased in people who are obese. And in an article from a number of years back in JAMA, the explanation for increased mortality in diabetics with cancer was from increased proliferation and metastases associated with hyperinsulinemia, hyperglycemia, and increased reactive oxygen species. So I ask, this is something that's on the tray of all of the cancer patients I see at San Francisco General. The ingredients here, and I list in red the ones that I think are all nicknames for different types of sugar. And I'm sure many of you also work at places where this is the supplement that's given. I can ensure you that it's not. Okay, all right. Need I say? I don't need to give that any more of a boost. So, now, I don't want to get us in trouble here. So I think a very exciting and interesting field, but one that I have two feelings about, is the use of metformin. So metformin, many people are not aware, is actually from the French lilac, so it's a bit of a natural substance. And epidemiologic studies, in contrast to what we've shown about insulin, show a decreased cancer risk in diabetics on metformin. And metformin appears in vitro to inhibit prostate, ovarian, and breast cancer cells. Many of you may have seen James Watson, the co-inventor or co-founder, whatever it is, of DNA, had a little +1 article that basically said we have a great anti-cancer agent right at our fingertips, the most widely prescribed medicine in the world, pennies a dose, selectively kills cancer stem cells. Metformin has been shown to do that in the test tube system. So if you go to clinicaltrials.gov and look at metformin.cancer, last I looked, there were 178 ongoing clinical trials in the country looking at metformin adjunctively with treatment of a number of different cancers. Now, of course, I see a lot of patients who say, can I get metformin now? What I generally do, the only 3 tests that I usually measure in my cancer patients are vitamin D, 25-hydroxyvitamin D, hemoglobin A1C, and HSCRP. And, you know, if they have an elevated hemoglobin A1C, I recommend that they talk to their oncologist or their primary care provider about possibly thinking about adding metformin. Certainly, I think it's better to lose weight and modify your diet, but we live in this American culture where people think if you're not taking a pill, or if you do take a pill, that's the easiest way to deal with these lifestyle things as opposed to dealing with the lifestyle things. I had a woman with pancreatic cancer, and there is some evidence that pancreatic cancer may be responsive to metformin. Pancreatic is the worst cancer, and she told me her oncologist said no, he's not going to give her metformin because there's not good evidence yet. Pancreatic, the poor lady has, what, 6 to 12 months of life, and she doesn't have time to wait for the evidence. So she said, will you talk to my primary care provider? So primary care provider and I had a conversation, and she said, this is my most widely prescribed drug in my clinic. It's totally benign. It's cheap. Just, I'll give it to her. And I said, well, do you want me to send you literature? She said, I've got 3 kids. I don't have time to read literature. I said, okay. You know, now, some of the patients who are not diabetic who begin metformin do have some gastrointestinal effects. I would say start with the lowest dose. Again, better to participate in a clinical trial because we don't really have the evidence. The next recommendation says to eat more of a variety of vegetables, fruits, whole grains, and legumes. And unfortunately, although USA Today just this week had an article saying that we're getting better and that fruits are now our #2 consumed food in the United States. I forget if #1 was soft drinks or not, but this shows that only 14% of adults are eating 5 servings of fruits and vegetables each day, and 5, I think, is a little bit conservative. A third eat 2 or more servings of fruit a day, and a quarter eat 3 or more servings of vegetables. The states that rank last are the ones where obesity is now approaching 40%. And even more disturbing, less than 10% of high school students meet these recommendations. We fall quite short from the guideline set up by Healthy People in the year 2000. So my strategies for my patients with cancer and my friends is to eat more phytoestrogens, such as soy, shown there from a market in Japan, flax seeds, cruciferous vegetables, season liberally with ginger, garlic, onions, and turmeric, drink green tea, obtain omega-3 fatty acids. That's actually tuna from the Tokyo fish market. It looks like beef, but it's tuna. And the same foods that are rich in omega-3 are pretty much our food sources of vitamin D. Now, one of the frequent controversies that I get from patients, particularly with estrogen-driven malignancies, is, are soy products safe? And now I've written 2 articles in the literature that do suggest that soy products, even though the isoflavones act as selective estrogen receptor modifiers, that in fact they are safe in women with breast cancer. And the biggest support for this came from a study conducted by Kaiser called LACE, Life After Cancer Epidemiology, where about 2,000 women cancer survivors were followed for 6 years, during which time about 300 recurrences occurred. And the investigators had asked very detailed food intake questionnaires, particularly focusing on soy products. And they found that soy intake at levels comparable to those consumed in Asian populations, that is a daily serving of whole soy foods, actually reduced the risk of recurrence, even in women who are on tamoxifen, which is a selective estrogen receptor modifier that we were concerned would compete with soy. So in postmenopausal women, there was about a 50% reduction in the risk of recurrent breast cancer in women on tamoxifen who ate Asian amounts of soy. And although it says further confirmation was required, a study in Shanghai, equally large, demonstrated the same. And when I say whole soy, however, what I mean is soybeans, soy milk, tofu, tempeh, and miso, and not soy cheese, soy turkey, and soy hot dogs, because those are not good soy products. Well, that's a photo from New Zealand that I took. The fifth guideline is limit consumption of red meat, beef, pork, and lamb, and I think those are sheep or something, and avoid processed meats. And I think avoid is a pretty big word, and so the guidelines are telling us to avoid processed meats. This is a slide from David Servan-Schreiber, who wrote the book Anti-Cancer, now deceased, psychiatrist with brain tumor, also French, so hence he spelled pork differently. But he's showing us the transformation of our food chain in the United States and the ratio of omega-6 to omega-3 fatty acids in various foods in 1960 compared to 40 years later. Andrew Weil, in his book Healthy Aging, described poultry and eggs as the most pro-inflammatory foods out there. And in fact, an egg that used to have a 6-to-3 ratio of 2-to-1 is now 20-to-1. So certainly if people are eating eggs, they need to be organic omega-3 eggs to get back to a better ratio of omega-6 to omega-3. Now, just this year, there was quite a bit of controversy excuse me, about omega-3s and their role in increasing, perhaps, prostate cancer risk. The investigators who published this in the Journal of the National Cancer Institute had already demonstrated that men with high blood concentrations of long-chain omega-3 fatty acids seem to have an increased risk of prostate cancer. So they took specimens from the SELECT study, which was a study that was meant to determine whether supplementation with vitamin E, selenium, both or neither, could reduce the risk of prostate cancer, that showed that actually vitamin E supplementation seemed to increase risk. And they looked at their plasma levels of the aggregate omega-3 fatty acids, individual ones, and then trans fat. And what they described was that those patients with cancer compared to patients without cancer had higher levels, and it was statistically significant, of the omega-3s. And it didn't take into account whether or not they were supplementing. But if you look at the second column, the first line, I don't have a pointer, total cancer, it's 4.66, whereas those without cancer is 4.48, which is not a huge difference in the levels, probably not a clinically significant difference, but it was statistically significant. So I believe that this study, counter to my belief system, is a fluke. And interestingly, just a few months ago, 6 weeks ago, New York Times, in an article about Chinese medicine, had this quote: "Historians of science since Thomas Kuhn have pointed out that legitimate science rarely abandons a theory the moment falsifying observations come in, preferring instead, sometimes for decades, to chalk up counter evidence to experimental error. The next day, and I put there, but I had to take it out because I didn't have a copyright, investigators at UCSF reported in a meeting that increased fish intake is a way to reduce the risk of prostate cancer. So, too many different conflicting reports here. The study that I like best on prostate cancer is this study that was published a few years back, done at UCLA, in 48 men who are going to have their prostates removed. The men were randomized to a low-fat diet where 15% of their calories came from fat, and they were given 5 grams of fish oil as a supplement. Now, Andrew Weil, in his book, Spontaneous Happiness, says he used to use fish oil for treatment of his depression and uses 4 grams. So I'm going to give you another little tip here. In Ayurveda, I've heard that fish oil is used to lubricate the colon and helps treat constipation. So I've never been either depressed nor constipated, nor have I taken 4 or 5 grams of fish oil a day. I usually take 2. So I decided I was going to see what 4 grams of fish oil did to my mood. Well, it didn't change my mood, but it definitely lubricated my colon. So for our cancer patients who are constipated, increasing fish oil is a good thing to do. But back to the study. So this gave them a omega-6 to omega-3 ratio of 2 to 1, or men were randomized to just eat the control Western diet, which is 40% calories from fat, and omega-6 to omega-3 ratio of 15 to 1. And they were brought these foods prepared by UCLA chefs for 4 to 6 weeks before their prostates were removed. Unfortunately, in this study, so that it could be a small study, the primary endpoint was serum levels of insulin-like growth factor 1, and at the end of the day, there was no effect on serum insulin-like growth factor 1 levels. However, those patients that were randomized to the low-fat, high omega-3 group had lower omega-6 to omega-3 ratios in both their blood and their prostate, less prostate tissue, both benign and malignant, and their cancer cell proliferation, as measured by their Ki-67 index, was also decreased. Even more interesting, the plasma of those men who were on the experimental diet, when added to prostate cancer cells in vitro, decreased proliferation of the cells more than the control group. So to me, yeah, I think omega-3s are good, and studies have also shown that they're beneficial in lung cancer patients undergoing chemotherapy. But it's not just the fat in meat that is what we need to avoid. It's the heme iron, which is also positively associated with the development of colorectal cancer, nitrates in the processed meat, and then unfortunately for people that like to barbecue, barbecuing meat and burning flesh creates heterocyclic amines, and these are also positively associated with the development of colon cancer. Now, an article that I read in 1989 influenced how I practice medicine. The article was entitled Treating Hypercholesterolemia, and it said in 1989 with the drugs that we had that if we treat 100 people, we actually benefit 4 and save 4 from having cardiac events. And I just went back to look at that article because I was teaching the medical service, and I found this in that article that I wanted to share. Physicians should recognize the qualitative differences between advising changes in diet and prescribing drug therapy. In the case of diet and other types of behavior, a patient can determine on a daily basis what is appropriate. As long as a recommended type of behavior is at worst harmless, it may be ethically proposed without unequivocal proof of benefit. The possibility of benefit may suffice. On the other hand, pharmacologic interventions are powerful symbols of the triumph of medical technology. Patients are likely to believe implicitly that the benefits of drugs clearly outweigh the risks. The physician who proposes drug therapy is therefore obligated to offer relatively stronger evidence of a favorable ratio of benefit to harm. I think this really speaks a lot about what we do in integrative and holistic medicine, and I enjoyed that. So this is my cabinet at home. The one that I'm highlighting, well, first we'll point out the alcohol guideline, which is a bit schizoid because it says, if consumed at all, which sounds like a strong statement, limit consumption of alcoholic beverages to 2 a day for men and 1 a day for women. And for women at risk for breast cancer, I often say 1 a week. So, and that's because there's a linear relationship between glasses of alcohol consumed per day and the risk of estrogen receptor positive breast cancer in women. But the one I wanted to talk about now is don't use supplements to protect against cancer. The first study that was really the largest study to try to investigate this question was called the CARROT study. And it was a study of vitamin A and as beta-carotene and vitamin E in cigarette smoking men. And it was 30,000 men, and what they found was that beta-carotene increased the risk of lung cancer in those men, which is the reason that I don't take any multivitamin or any vitamin A because, believe it or not, as an oncologist, I even smoked a pack a day of Marlboros for many years. So I won't take a multivitamin because I'm avoiding beta-carotene and vitamin A, although I am carotenemic because I eat a sweet potato every day in the winter. So natural source is fine, but the supplement I'm concerned about. In the CARROT study, they observed that the men randomized to the vitamin E arm seemed to have a lower risk of prostate cancer, but the study wasn't powered for that, so they did a second study of 35,000 men called the SELECT study, which I mentioned previously, where patients were randomized to selenium alone, vitamin E alone, both, or placebos. And as you can see, there are about 9,000 men in each group. And the study enrolled for 2 years, and then ultimately, 5 years later, the Data Safety Monitoring Committee asked the participants to discontinue their blinded treatment because they said there was no way that there was going to be a 25% reduction in the risk of prostate cancer in any of the arms. And in fact, they perceived an increased risk of prostate cancer in the men receiving vitamin E. There was also an increased risk of diabetes in the patients that were treated with selenium. Well, a follow-up to this study was published, again, at the request of the Data Safety Monitoring Committee in JAMA a few years later. And what they found was that, in fact, vitamin E supplementation significantly increased the risk of prostate cancer in healthy men. Another reason that I'm not taking a multivitamin. However, opponents of this interpretation point out that in most multivitamins and in most of these clinical trials, vitamin E is D-alpha tocopherol. In nature, vitamin E lives in 8 isoforms: alpha, beta, gamma, and delta tocopherol, alpha, beta, gamma, and delta tocotrienol. So when the body sees 400 times its daily requirement of D-alpha tocopherol, it's not going to absorb the gamma tocopherol from the walnut or the pistachios, and it may be that it's the gamma tocopherol that's of benefit. What I recommend to my patients if I want to give them vitamin E for hot flashes or for neuropathy is that they take a form of vitamin E that has all 8 isoforms, and they're out there, or to take a spoonful of wheat germ oil, which is a good natural source of vitamin E. Even B vitamins. Wow, B vitamins, if you take too much, you just pee it out. That's what makes your urine that fluorescent orange color that some people think is attractive. Anyway, we fortify baked goods in the United States with B vitamins to prevent babies from being born with neural tube defects. They don't do that in Norway. So in Norway, they took patients with ischemic heart disease and treated them with B vitamins or placebo to ascertain whether or not they could decrease the risk of death from cardiovascular disease. Patients were randomized to folic acid, vitamin B12, and B6, folic acid and B12, B6 alone, or placebo. And in this study, the results were obtained after a median of about 3.5 years of follow-up. And the bad news was that patients who were randomized to folic acid and B12 had increased rates of cancer, cancer mortality, and all-cause mortality. Now, personally, I think that the culprit here is folic acid. Folate is from nature in green leafy vegetables. Folic acid is synthetic. And there's a very narrow range of toxicity efficacy in folic acid. Studies have shown that 1,000 milligrams a day increases prostate cancer in men. One of the reasons we believe that we haven't seen a decrease in colon cancer despite colonoscopy is because folic acid fuels adenomas so that they can continue to grow and divide and become adenocarcinomas. So again, something as benign as a B vitamin, which we would think we just eliminate if we don't need, can actually cause problems. So the American Cancer Society's statement on supplements says there is strong evidence that a diet rich in vegetables, fruits, and other plant-based foods may reduce the risk of cancer, but there's no evidence at this time that supplements can reduce cancer risk, and some evidence exists that indicates that high-dose supplements can increase cancer risk. So I'll talk more about supplements in my sessions this afternoon. But one question that I frequently get from my patients that I did want to discuss now is, can I take this? And patients often come in with their shopping bag full of supplements that have been given to them by their cousins or their next-door neighbors whose mailman's sister had exactly the same cancer that she cured by taking this mud from Wyoming. I said, okay. Anyway, so there I am with my green tea looking at the supplements, and I'm looking as if I know the answer, you know. Can you really take this? Well, these studies have not been done. So am I giving an evidence-based response? No, but I think I'm giving an evidence-informed response. And the two issues that I'm trying to sort out are, is there a potential for a botanical drug interaction? As you know, the cytochrome P450 system, particularly the isoform CYP3A4, is involved in the metabolism of many chemotherapeutic agents as well as many botanicals. St. John's wort, SJW, is a botanical that's used for treatment of mild to moderate depression. It should never be used in cancer patients who are receiving chemotherapy because St. John's wort increases the metabolism of the anti-cancer drugs. The largest number of botanical drug interactions has really been done with St. John's wort, and it's been shown to decrease the area under the curve by about 30%. So an oncologist is prescribing, based on the body surface area, a fixed amount of chemo for the patient, and the patient's taking St. John's wort, which is decreasing that chemo by 30%, allowing the cancer to become resistant and the chemo to be ineffective. On the other hand, I don't see many patients who take ginkgo during chemo because maybe they don't want to remember, but ginkgo inhibits the enzyme system. So if patients were taking ginkgo while they were getting these chemotherapeutic agents, the levels of the chemotherapy would increase, as would the toxicity. So that's not good. The other question that patients are really asking when they say, can I take this, is there going to be some oxidant-antioxidant issue? As we know, oxygen exists as two molecules linked together. That's what we breathe. But when those oxygen molecules separate, they create free radicals or reactive oxygen species, which knock into our DNA, causing damage, which leads to aging or cancer. Antioxidants take those free radicals out of circulation. Radiation therapy creates free radicals of oxygen so that it could knock into the cancer cell's DNA and kill the cancer. Some chemotherapeutic drugs also create free radicals of oxygen, and those drugs are shown here. So if we're purposely creating those free radicals, do we want patients to quench those with antioxidants while they're getting treatment? Again, some of the useful antioxidants that patients might want to take are listed here, and I'll be talking about some of them later this afternoon. What do we really know about this? Radiation therapists will tell all patients not to take any antioxidants while they're receiving radiation therapy. In fact, some will go so far as to say, only eat white foods while you're getting radiation therapy. Well, that's ridiculous. You know, that blueberry versus that beam of radiation, who do you think is going to win? So their phobia is based on one clinical trial, which was done in 540 patients with head and neck cancer, randomized to receive alpha tocopherol or beta-carotene. They were treated during radiation therapy and subsequently for 3 years thereafter. However, the beta-carotene arm was discontinued in the middle of the trial with the results of the CARROT study because so many patients with head and neck cancer were cigarette smokers or former smokers. So what we have now is information in the patients who are on the vitamin E. And the supplements decrease overall adverse events during chemotherapy, which is actually what they were looking for, although it was not quite statistically significant. With the combined supplements, it was statistically significant. The median duration of follow-up in this cohort was 51 months, and they had local recurrence diagnosed in 103 patients. The hazard ratio, or the risk for recurrence with supplementation, was increased, again, but that was not statistically significant. But in the alpha tocopherol, neither one of them were statistically significant. However, in a follow-up study, at 6.5 years, the all-cause mortality was increased in the supplement arm, and that finally was on the other side of 1. Everything was on the same side of 1. So it was statistically significant, suggesting a 40% increase in mortality in patients who received vitamin E during radiation for head and neck cancer. That's the only study that shows a detriment to antioxidants during treatment. Keith Block, who publishes Integrative Cancer Therapies and is a pioneer integrative oncologist in Evanston, Illinois, put together a systematic review of 19 randomized controlled trials of antioxidants in patients with cancer and showed either significant advantage or a non-statistically significant increase in survival or treatment response. However, I will say that the antioxidants mainly were glutathione and N-acetylcysteine, which are not frequently used antioxidants by the patients I see in San Francisco. He found no evidence of diminished effect of chemotherapy in this systematic review. Now, the authors of the chapter on antioxidants and cancer in my textbook, Integrative Oncology, did not feel that this study was worth including in their first iteration of that chapter. So my individual advice to patients with regards to antioxidants really depends on the goal of treatment. If my goal is to cure the patient, or if they're receiving adjuvant chemotherapy for breast or colon cancer, the tumor's been removed, we're trying to prevent it from coming back, why mess around with the uncertainty? Let's just hold off supplemental antioxidants until the chemo and/or radiation is completed. My breast colleagues across the street at UCSF tell their patients, stop your supplements the day before, the day of, and the day after your chemo. Now, that doesn't take into account the half-life of the chemotherapy or the supplements, so that I don't think is wise. An antioxidant-rich diet is fine, so forget about white foods. That's crazy. If the goal is palliation, then maybe some judicious use of some supplements might be fine. But I think as oncologists, we're a bit schizoid because we prescribe expensive intravenous antioxidants to protect patients from some toxicities of chemotherapy, and we don't really worry about what's happening to the tumor. Now, let me go back to stress. I think this is a very interesting quote, especially since it was in the National Cancer Institute bulletin, but I think it's flawed in its logic. With all that we know about how stress aggravates cardiovascular disease, promotes viral infections, exacerbates metabolic diseases, halts reproduction, and regulates the normal function of virtually every cell in the body, why would cancer cells somehow be exempt? Well, because they are. That's why they're cancer. They don't respond to everything else that normal cells do. But as I mentioned, there is not much evidence that stress in and of itself directly causes cancer. It's neither necessary nor sufficient to initiate carcinogenesis. but stress hormones can accelerate the growth of established tumors. The study that I mentioned previously, they had mice with breast cancer, metastatic, and one group of mice were confined to a small space for 3 hours a day, whereas the other group ran free. And at the end of the study, the confined mice had their primary lesions were the same as the control group, but they had increased size and number of metastatic lesions. So stress is not good, and now they're narrowing it down to catecholamines, which are leading people to say, maybe we should use beta blockers in cancer patients adjunctively. I say, no, let's decrease stress. You know, this is the American way. Taking a pill is the way to do it. Aspirin decreases cancer risk. Well, what is that little aspirin doing? Decreasing inflammation. Why don't we eat right and exercise, and then you don't have to take these pills? Now, there is increasing evidence that stress seems to be related to more aggressive cancers. This is a study of women with ovarian cancer who were found to lack social support and have higher levels of distress. Their tumors had higher levels of vascular endothelial growth factor, which makes them more aggressive. And that was the first association between a psychological factor and a cytokine involved in angiogenesis. And that was confirmed by a more recent study looking at 37 newly diagnosed head and neck cancer patients with squamous cell carcinoma. Higher levels of perceived stress and depressive symptoms were significantly associated with greater VEGF expression. This is a little bit chicken and egg, which came first. We're not really sure, but those patients who had intense VEGF expression had mean perceived stress scores that were 47% higher than patients with weak expression, and the associations were stronger for earlier stage patients, and those who had high VEGF were more than 2.5 times more likely to die. So that's pretty impressive. But let's not take a beta blocker. Let's use some of our integrative and holistic approach to decreasing stress. Support groups, journaling, disclosure, guided imagery, hypnosis, breath work. Here's a study in 200 women who were scheduled for breast biopsy or lumpectomy, randomly assigned to hypnosis or a control group preoperatively. So the hypnosis group had a scripted 15-minute session within an hour of surgery, whereas the control group spent 15 minutes with a psychologist receiving emotional support. And everybody was blinded to which group the patient was in. Women in the hypnosis group required less anesthesia, although the same post-op pain meds, reported less pain intensity, unpleasantness, nausea, fatigue, and importantly for insurers, spent 10.5 minutes less in surgery, saving $770. We laugh, but that's how insurance companies are going to reimburse us for our integrative interventions if we show that they're cost effective. In conclusion, in a past life, I was a practitioner of traditional Chinese medicine. It speaks to me, although I don't understand it. But I believe all of my patients with cancer benefit from being co-managed by a traditional Chinese medicine practitioner. Traditional Chinese medicine is all about expelling evil and supporting good. Modern Western medicine focuses on expelling evil. When patients come to see me at the Osher Center, I'm supporting good. But when they go to a traditional Chinese medicine practitioner, they do both at the same time from a different angle. So instead of saying they have metastatic breast cancer, they say they have decreased spleen qi and increased kidney yang, and they treat that. And I find that very important. And I believe that my patients who are being treated with chemo, radiation, targeted therapies, hormones, tolerate their treatments better if they're getting acupuncture. In 1998, the NIH had a consensus conference that concluded that acupuncture was effective as an antiemetic during chemotherapy. Since that time, we also know that it's useful in many other cancer-related conditions. Let me just review a few. You know that women with postmenopausal breast cancer on aromatase inhibitors, about 20 to 30% stop their treatment because of musculoskeletal symptoms. This was a small study where patients were randomized to either true or sham acupuncture. Whether or not there's such a thing as sham acupuncture could be the basis of another hour presentation. But at the end of the day, the patients in the true acupuncture group had a 50% reduction in pain from baseline compared to no change in the group that received sham acupuncture. Acupuncture has now been shown to be equal to standard therapy in both men and women on hormone therapies that produce hot flashes. The question is it safe in people with low counts, with low platelets, or with lymphedema? And studies have shown that acupuncture is safe in all of those conditions. It's been shown recently to be effective for cancer-related fatigue in breast cancer, and a very big problem that we have in patients with head and neck cancer getting radiation is dry mouth. Patients who get acupuncture while they're getting radiation have a decreased risk of xerostomia. So, in conclusion, an article by Gary Dang and Barry Cassileth at Memorial Sloan Kettering, just published a few weeks ago, reported the essential elements for success for an integrative oncology program. Their belief is that the integrative oncology program should be located within the oncology department. Oncologist referral to consultation with an integrative oncologist should be the first step. At our site, many of our patients come first referred to a traditional Chinese medicine practitioner or a massage therapist, and then ultimately make it to the integrative oncologist. There should be sufficient time for integrative oncologist consultation. When asked, does what I do make a difference, I will say I've now been practicing at the Osher Center for Integrative Medicine for 8 years. At the beginning of my consultative practice, most of my referrals came from Andrew Weil or from website surfers. Now most of my referrals come from my colleagues across the street at the Cancer Center, suggesting to me that they appreciate some difference in their patients' outcomes if they're co-managed by me versus not. Integrative practice that is evidence-informed, I changed that because Barry Cassileth and Gary Dang are very evidence-based. So that's my asterisk or my hyphen there, or what is that? Italics, yes. Professional complementary medicine practitioners and coverage for the cost of integrative oncology services. So again, this is the Cancer Center on the left, and the Osher Center for Integrative Medicine is the new building. We have 3 stories, the upper 3 stories. The 3rd floor is our research wing, the 4th floor is our clinic, and the 5th floor is education and administration. And even though we're across the street, and Gary and Barry think that we should be in the same place, we still have, I believe, effective integrative oncology services for patients living with and beyond cancer at the University of California, San Francisco. And with that, I'll stop, and thank you for your attention.